I warmly welcome Dr. Lars Kristensen from the Parker Institute in Copenhagen, and a warm welcome to you. Thank you for coming. We're going to discuss the paper you published in Rheumatology recently on the link between obesity and biological use in psoriatic arthritis. So Dr. Kristensen, maybe you can explain a little bit about the design of the study?
Yeah, that's true. We conducted this study and presented it at EULAR and recently published in Oxford Rheumatology, and it's a cohort study, an observational cohort study using the Scandinavian registries, DANBIO and ICEBIO, so it's actually nationwide for the nation of Denmark and nationwide for Iceland, and we pooled the data. And our endeavor was to look at the relation between BMI stratified in being obese above 30 or below, and to see how that impacted drug survival in the first course of anti-TNF treatment in psoriatic arthritis. Yeah.
And how many patients did this involve?
Yeah, it involved about 3,000 patients.
Right, that's a lot, right?
Yeah.
And all with psoriatic arthritis. So what were the key results of your study?
The key result was, and not surprisingly, that the drug survival was negatively associated with obesity. So if you had a BMI above 30, you were at a greater risk of dropping out of treatment prematurely. And we both overall, but we also went down and stratified according to sex, and we saw that actually even more so for male gender, they were a bit more exaggerated. The hazard ratio were about 80% increased, 1.8, and for women it was about 1.5. So there was a significant risk for both genders.
Right,
yeah.
Right. And do you have any inclination why this gender difference occurred?
Yeah, I mean, as always, you have to be careful with these observational studies, because we can say association making causation is a bit more difficult, but so they are confounding factors. But one could speculate, that obesity has been found to be a low inflammatory driver, and we also saw that in the baseline when we stratified in obese, non-obese, that even it was not just the patient-reported outcome, but even the joint counts and CRP were numerically higher, and the DAS score was higher for the obese. And then you can argue male obesity might be more abdominal obesity, and in that sense also being associated with more inflammatory, actively adipose tissue. And in that sense, you could speculate that this might even activate the psoriatic arthritis and making that harder to treat. But I think that's probably going a bit too far with the data. But we saw it and we reported it, and that's what we found. Interestingly, we also looked in not only at drug survival, we also looked a little into treatment response. And we found for the EULAR overall response, that is EULAR moderate plus good as a pooled outcome, we also found that the obese had a significantly poorer response rate than those that were not obese. But for other response criteria, the ACR response, we didn't find any differences.
Right. So a final question. So when you talk about drug survival, was drug stopped because of inefficacy or because of side effects in these patients?
Yeah, and that is always a good question. And I prefer personally not to go into detail with the cause of cessation of treatment, because often it's not clear cut. Yeah. If you're experiencing a little more side effects, you're more prone to stop if the efficacy is suboptimal. So there's a kind of an interaction, and we try to go down to that, but we are not too too reliable on the data for the cause of cessation. So I won't really do any interpretations on that.
Yeah. Okay, well, thank you very much for explaining. This was, I think, of great interest for our readers, and I encourage all the readers of the journal to pay attention to this paper. And thank you for coming.